Good afternoon, everyone. And thank you for joining us this afternoon. My name is Donna Girardi, and I'm the president of the National Association of Academies of Science. We are a nonprofit organization that represents all of the state and regional academies of science distributed across most of the states. And we have a wide variety of programming among our academies, including educational programs, public programs, and increasingly, a number of our academies are very interested in the science and policy interface and ways to engage our resident scientists and engineers in informing policymakers. And so we are moving into some new directions with our association over the last couple of years and creating new kinds of partnerships and collaborations. And we're really delighted today to be launching our first affiliation with the National Academies of Sciences, Engineering, and Medicine through its SEAN, Societal Experts Action Network program there. And we're really excited to be able to help bring the wonderful work that the National Academies does that informs national science policy and its connections there to you as state academies and state affiliated groups. This is the first time we're doing this, and we're really excited about it. And we would like to have all of you add your state affiliations so we know who is here. And just a brief note about the purpose of these events. Over the last few years, we've been expanding our programming for academies. We have monthly activities that we call Academy Chats. They're opportunities for our state academy, member academies to get together and both share what they're doing and learn from each other about a wide range of activities that academies are involved in. And increasingly, there is an interest in science policy. We've used Academy Chats to learn about what each other is doing in certain topics, and also inviting in other national level activities to describe what they do and how they do it. And we're particularly happy that the National Academies is here. As you all know, or probably all know, the National Academies puts out so many different kinds of reports on so many different areas of science and technology that touch every aspect of life in the states. And so we're really thrilled to use this as an experiment to see how we can engage in conversation from the national level into the state level at a time when those kinds of conversations are increasingly important. I'm going to turn it over now to Malvern Chiwese from the National Academy of Sciences to describe a little bit more about the SEAN program and what we're going to do today. So I'm happy to say I've worked with Malvern on another activity a few years ago where the National Academy's report that had come out on wastewater surveillance. We collaborated on an activity here in Washington State where I'm in Seattle, and it was really a terrific engagement of national level scientists and researchers on that topic interacting with our state level policy and our county level policymakers. It was really a terrific event. So Malvern, take it away.
Thank you, Donna. Yeah, I'm really happy to be here, and we are really happy that this is happening. So I'll just say brief remarks around what we do at SEAN. So we were started in 2020 as a direct response to the COVID pandemic. We are funded by the National Science Foundation, and really what we do is to try to provide actionable evidence-based guidance to policymakers at all levels. We're increasingly finding that we are more helpful in states where sometimes it's difficult to connect with evidence. We do webinars and what we call peer-to-peer events like this event today here. We have written about 21 rapid express consultations since the onset of COVID on a number of topic areas. We've done things on vaccine confidence, disaster preparedness, social isolation and loneliness. We're actually currently working on our consultation number 22, which will be on AI and state and local government decision making. We are really hoping that this is the start of many events that we'll do with NAAS. I think there's a realization from the top management of the academies that we really need to capacitate National Academies of Sciences to be doing science policy and translation work within states. Back to you, Donna.
Great, thank you. I think the desire for that kind of a dialogue is going both ways. I'm hearing that it's coming from the national academies, but it's also coming up from the state level as well. And so this is just perfect timing for this new kind of collaboration. What I'd like to do now is just go around the Zoom Hollywood Squares and have you each introduce yourself just very briefly. And I'll start with Hallie Thompson.
Hi, Hallie Thompson joining today from Missouri. I do staff support work for the National Association of Academies of Science, and I'm excited to be the person who gets to organize these Academy chats and support them from a staff perspective. And wonderful to see you all.
Hallie is also involved in many other science policy activities around the country, ranging from science and technology fellows programs to lots of other things. So she's much more than administrative support for us. We're happy to have her. Okay, Cecilia.
Good afternoon, everyone. My name is Cecilia Gonzalez, and I'm a project director here at UNC in the Injury Prevention Research Center.
Amanda?
Hi, Amanda Fuller. I'm the executive director at the Kentucky Academy of Science, and I'm in Louisville.
Amanda Dale.
Good afternoon, everyone. I'm Amanda Dale. I'm a research specialist at the North Carolina Institute of Medicine, calling in from Durham, North Carolina.
Nidhi Sachdeva.
Good morning, afternoon, wherever you are. I'm Nidhi Sachdeva. I'm the Director of Strategic Health and Opioid Initiatives with the North Carolina Association of County Commissioners, tuning in today from Raleigh, North Carolina.
Catherine Gora Combs.
Hi, everybody. My name is Catherine Gore-Combs. I'm a co-investigator of the Core NC project, which you'll hear Nidhi and Cecilia talk about briefly, calling in from the Research Triangle also.
Okay. Jeff Orszak. Oops, you're on mute, Jeff.
Sorry, I was pressing the space button, but didn't work. I'm the executive director of the Connecticut Academy of Science and Engineering.
Bridget Kelly.
Hi, everyone. I'm Bridget Kelly. I'm based in Port Townsend, Washington, and I have a consulting practice where I work with both Sean and the Washington State Academy of Sciences. So I love this matchmaking. And I trained in North Carolina. So today is really a good day for me.
Oh, great. Philip Winchell.
Hello, everybody. My name is Philip Winchell. I'm the archivist of the National Association of Academies of Science. And also, I am calling in from near Dayton, Ohio, which some of you will know was one of the absolute center points of the opioid epidemic. So very interested to hear what's going to be said today.
Thank you, Philip. Vinay Raj.
Good afternoon, everybody. My name is Vinay Raj. I'm the president of the Arkansas Academy of Science. I'm also an associate professor at the University of Arkansas at Pine Bluff.
Great, thank you. Annie Ching?
Yep, Ching. I'm Annie Ching. I'm the senior program manager for substance use disorder at the National Association of Counties. So I work sort of closely with Nidhi from the North Carolina Association of County Commissioners. But I'm happy to be here. I'm in DC.
Thank you. And Drew Spear.
Hey, good afternoon, Drew Spear, University of Kentucky College of Public Health, from the Lexington area.
Okay, thank you. All right, well, this is a great group, and I'd just like to acknowledge a couple of my close colleagues at NAAS, including Amanda Fuller, who is actually the person who originated this idea of Academy Chats when she was president of the organization a couple of years ago. And it's her vision to create this virtual way during the pandemic in particular to get us meeting and around the topics we cared about. So thank you, Amanda, for that. And then Philip Winchell, who's also on our board, who is just so involved in NAS activities, especially our American Junior Academy of Sciences program, where he's been spearheading some really innovative work in that area. So thank you for joining us today. We're going to begin our speaker presentations by our panelists, and specifically about the 2021 National Opioid Settlement as an example of research informing policy. We all live in states where this is playing out in very different ways, and so we're looking forward to hearing how North Carolina in particular has addressed this. This is going to be a moderated, each of the presenters will give brief bios about themselves. They'll do a much better job about that than I can do. And then we're going to, after their presentations, we're going to have a moderated discussion with them, and we'll follow to address the audience questions. So when we get to that point, please use the hands up function in Zoom, and I will call on you. And with that, I'm going to turn it over to Cecilia Gonzalez to begin her presentation.
Thank you so much, Donna. Like I said, my name is Cecilia Gonzalez, and I serve as the project director for the Community Opioid Resources Engine for North Carolina. My position is held at the UNC Injury Prevention Research Center, where I have worked about nearly 3 years now on CORE-NC, and I've also worked across various departments in public health research at UNC for over 17 years now. And just to provide a little bird's eye view here to kind of set the stage, the national opioid settlements are likely to exceed $56 billion in total across the nation. And then for just some additional reminders, these settlements and bankruptcies resolve litigation over the role companies had in creating and fueling the opioid epidemic. I'm just gonna, the little picture window is distracting me. So for North Carolina specifically, we are handling things a little bit different. If you look from a national perspective, each state kind of has their autonomy and how they choose to distribute the funds. So you'll see states doing it differently across the nation. But for North Carolina specifically, we are set to receive just over $1.4 billion across this 18-year payout period, which began in 2022. And our state model allocates 85% of the funds directly to local governments, whereas 15% is controlled at the state level. And learning from the tobacco settlement historically, North Carolina set the intention early on to lead with transparency and accountability this time around. And we are lucky in North Carolina that we have this legal binding document that all local governments signed onto as part of their agreement to receive these settlement dollars directly. And the North Carolina Memorandum of Agreement directs how opioid settlement funds are distributed, how they are used, and how they are reported in our state. And the MOA includes these 5 broad requirements for local governments. To continue receiving the funds directly, they have to abide by these 5 broad principles and rules. But how would North Carolina ensure adherence to its pillars of transparency and accountability? That's where CORE-NC comes in. And we were established as a centralized hub for all things related to the opioid settlement funds in North Carolina. When the Department of Justice created and developed and wrote the MOA, they partnered with 3 other organizations with various levels of expertise to help them monitor and enforce the use of the opioid settlement funds across the state. Again, to ensure that we are leading with that transparency and accountability. And we'll go into a little bit more detail later on how this collaborative approach is key to our success here in North Carolina. But I will focus my presentation on UNC's role in this project. Our team, as I mentioned, is based in the UNC Injury Prevention Research Center. And this research center has a long and rich history of research on programs and policies that reduce the impact of injury and violence in North Carolina and across the world. And more broadly, Core NC established 2 systems to assess local governments as they kind of go through the MOA process and abide by all of the rules within. Now, Nidhi's presentation will kind of focus on the TA side, but I will kind of focus on the information clearinghouse side. And for this project, the UNC team has been tasked with the development of annual reporting, the collection of all of the required data for local governments, processing and cleaning that data, and then ultimately visualizing it all on the Core NC website that we continue to maintain and grow as the years go on. And so here are the kind of 3 buckets that we take the lead on, which I'll go into a little bit more detail for all of us data nerds out here. So we use Qualtrics to program our online surveys to collect all of that required annual reporting or reporting data. And then the Core NC team at UNC has both manual and programmatic methods to continuously monitor all of those incoming reports for completeness and data quality. And about a year ago, we introduced this nifty little feature, the doc library, that serves as a repository for all of the submitted documents that we receive from local governments. And you'll see here, we took a screenshot of it here. You can filter our doc library at various levels. So you can look at specifically a local government, see all of the reports that they have submitted. You can filter by document type, or if you're looking for a date range, you can also filter by date. And one of the really cool things about this is that, as I mentioned, we have all of our incoming data through Qualtrics, but the back end, or once you finish completing a Qualtrics report, it's really messy. So we have a programmer on our team who is able to write a code, and it will suck in all of the information that they submitted in their financial report, for example, and it will create a summary document that's just much more easily digestible for the general public, and also serves as a really good resource for our local governments as they're looking to submit new financial reports or any new reporting data, that they'll have that kind of PDF summary of everything that they've submitted previously. So by far, our most popular part of our website are our data displays. And they kind of emphasize on this interactive approach, place-based data, so that local governments can see what is happening in their area, also see what's happening in their neighboring counties and across the state. So this shows the current list of available dashboards, including one that is coming very, very soon that you'll get a sneak peek of for the strategy implementation dashboard. So the first one is our payment schedule dashboard. And as the name says, this kind of just shows you what local governments are expected to receive in terms of opioid settlement funds across the 18-year payout. So the dark green bars show what they've already received in the previous fiscal years. The current fiscal year is that more aquamarine bar, and then all future years it shows in that mint green. So it shows it statewide, which is what this screenshot is, but you can also toggle down and look more granularly at local governments and what they are set to receive. As I mentioned, one of those requirements under the MOA is to submit local spending plans. So our state level trends dashboard gives an overall picture of the state and how local governments are electing to spend their settlement funds. And again, it kind of goes into a more level of detail to show the specific strategies that are being funded to date across our state. And you can link to the actual resolution PDFs within our dashboards and in our doc library, where you can actually see more specific details on the strategies that they're intending to fund, including how much money, the time frame in which they are planning to use those funds, and some programmatic level detail. And then the annual financial report goes into, we know what they intended to fund with their local spending plans, but what did they actually disperse in funds in any given fiscal year? So from the financial report, we then get more specific details on what local governments actually spent in the past spending dashboard. And again, it shows that same kind of granular by strategy information to cumulatively show what local governments have spent on various strategies to date. And just to note that, so this is based off of annual reporting, which is runs fiscal year to fiscal year. So July 1 in any given year to June 30 of that year. And then it's updated on our website, usually by January of each year. And then our local progress page came about from this problem that our users expressed of having to go to multiple pages to see a picture of what is happening locally for them. So one of the lessons we learned early on is that we really wish we had created a code that allowed our various dashboards or various visualizations to talk to one another. Unfortunately, we did not do that. So we had to go back and essentially do a whole code rewrite to allow our dashboards to talk to one another so that we could build this page where you first select the local government or the community that you want to look at. And then the page populates to show everything that is happening in that area. So it took a lot of work to create this local progress page, but it is one of my favorite parts of the website now. And then, as I mentioned, the little sneak peek, we are any day now, we are going to launch the strategy implementation dashboard. And it is focused on strategies that local governments have funded, where they're at in the implementation of that strategy. So again, this is going to be a state level view where you choose the strategy that you're interested in seeing what's happening across the state. It will populate to show who is funding that strategy, who has dispersed funds to that strategy, and then where they are at in the implementation of that strategy. And I think that this will go a long way to adding some important context to our annual impact reporting that will allow not only for the general public to get a better understanding that it takes time and effort and dollars to actually start seeing true impact of a strategy in a community. But it also gives another opportunity for our local governments to learn from one another. So let's say in year 7 of this opioid settlement period, a community is deciding that they're going to fund a new strategy. They could use this tool to see who is already funding that strategy, who might be a neighboring county of theirs. And if they're already in the full implementation stage, maybe they can reach out and learn from their neighboring counties of what they've done, the lessons they've learned, so that they can not start from ground zero in implementing a new strategy. It also should be noted that this is an optional piece of impact reporting for our local governments. So you will see that little dark gray portion will be that they're implementing that strategy, but they didn't provide us with the stage of implementation. So a theme to today's presentations, and honestly, a theme to our day-to-day work, is that partnerships are truly a key to our success. Each partnering organization of Core NC has their primary role, which you'll see on this slide, but we all work together to make that magic happen. And it has been vitally important to have the various different perspectives that these organizations bring to the table and the varying levels of expertise to build what I hope will be a sustainable infrastructure that will help our North Carolina local governments through this 18-year funding period and hopefully beyond. And again, I want to acknowledge that our model in North Carolina is very unique. These organizations have been working together for literally decades in the space of public health. So it was very natural and easy for us to come together, play in the same sandbox, not worry about egos getting in the way. And we lead by knowing that we have the same end goal in mind, and that we have this awesome opportunity to see real change across our state in an 18-year period. And we also have this opportunity to help our local governments paint this picture of success, of what they were able to accomplish, so that they would have all of the justification they need to continue including program funding in their local budgets, even once these opioid settlement dollars have ended. At least that is what our hope is. So I also just wanted to make note here that the UNC side of Core NC receives its funding from the 15% of the state level funds. And those funds are routed through the North Carolina Collaboratory, which is also located at UNC. And we have been very fortunate to work closely with the research program director there, Greer Arthur, who is very keen on further developing research projects that are more partnership focused. And they have currently a group of grantees funded through their opioid remediation research and evaluation program that pairs researchers with local government staff or community organizations that are set to receive opioid settlement funds. And the aim is to work alongside with Core NC's efforts to help local governments share their stories of success, build that impact of the strategies that they are implementing in their communities. And the goal is to have researchers be very adaptable to what is happening locally in these communities, be able to switch gears, modify things based on the needs of the communities themselves and based on the needs of these local government staff people that they are working with. So it's been a really great opportunity to be a part of this work with the North Carolina Collaboratory. And I just look forward to what the future of research might look like with the assistance of the North Carolina Collaboratory funding. So I know that has been a lot of information and we're just getting started. So I'm thrilled to pass the baton to my dear friend and colleague, Nidhi Sachdeva, to discuss her organization's role in providing technical assistance to our local governments. And I'm going to continue sharing my screen so I can just help her go through her slides.
Thank you so much, Cecilia. I hope you all are enjoying your days wherever you are. I wish that my background wasn't so washed out because I have a beautiful view of downtown Raleigh behind me. And it is quite distracting because this is probably one of the most beautiful times of year in North Carolina. So Bridget, come back and visit. But thank you so much, Cecilia, for setting us up for hopefully what will be a really interactive discussion after we get through our slides. But again, my name is Nidhi Sachdeva, and I'm the Director of Strategic Health and Opioid Initiatives with the North Carolina Association of County Commissioners. And I lead a team of folks that is the OSTAT team. We affectionately call ourselves OSTAT, which is the Opioid Settlement Technical Assistance Team. So I am just really delighted to be in this partnership with our Core NC partners. Like I want to just stress the fact, like that Cecilia pointed out, that we are, decades in the making of this relationship. Like the settlement is new, but that doesn't mean that the partnership is new or that this opioid overdose crisis is new to us. We've been, managing it now for 20 some years, and having been in public health in North Carolina now for nearly 20 years, half my life, I've sort of bounced back and forth between practice and research. So I've had positions both at academic universities at UNC and at Duke, and in local and state public health. And we'll have to admit, though, that my heart is very much with the community. And so you'll probably hear that today as I'm talking about some of the work that we're doing. But I'm currently sitting at the North Carolina Association of County Commissioners. We are a nonpartisan organization that serves as the official voice of all 100 counties in North Carolina. We are very much here to support our local governments in advocacy, education, training, research, and policy. And so counties, everybody in North Carolina lives in a county. And so we like to just say that we serve all people in North Carolina and try to do our best to represent the best interests of everyone. But within the NCACC, or the North Carolina Association of County Commissioners, we have a team of folks, like I said, called OSTAT. And so our directive is really to improve the health of all North Carolina counties. And in this moment, our main mission, I guess, or goal or purpose is to support local governments in utilizing the opioid settlement funds to maximize our resources and impact through technical assistance, outreach, training, and collaboration. So I'm representing a team of 7 of us, which is quite unique in that I think most states aren't so lucky to have such a large technical assistance team. But we are a collection of researchers, evaluators, public health planners, practitioners, program specialists, all sorts of folks that have been just in public health for, we did the math the other day. I think collectively across all seven of us, we have 100 years of experience doing public health in North Carolina, which is pretty wild. So through OSTAT, my hope is that at the end of this 18-year period, that all people in North Carolina are healthy and have connections to supports and services within a culture of care. We really embrace the social ecological model and this idea that all public health interventions are much more effective if we're working on more than one level. And so we emphasize that in all that we do and in the technical assistance that we provide. And so appreciate Cecilia going through and talking about the information clearinghouse. We very much pride ourselves in North Carolina that we are focused on data-driven decisions, and that includes just this commitment to transparency and accountability. So data on both ends. But we all know that the quality of data coming in isn't, it really is dependent. The data coming out is dependent on the quality of the data coming in. And so we know that technical assistance is a really key part in helping our local governments build their capacity to do good work, especially around this technical assistance that's just a new opportunity for them, right? And so our technical assistance is essentially at every stage of the process. So not only do we help local governments sort of understand what the MOA is, the memorandum of agreement, what the settlement opportunity is, but we help them walk through planning, implementation, evaluation, and reporting, and help them at every stage. So tiniest little questions, where do we send our reports to, what in the world do we even do with this opportunity when, and this need when it's so great and we have so little resources. And so we provide technical assistance through education and outreach, a lot of one-on-one coaching, consultations. It's a very tailored, customized technical assistance approach. We are not lawyers, but we do a lot of translating of what the MOA is. So what the boundaries of the terms of the MOA are, what they can and cannot do with the money, what's allowable, what makes sense, and also do a lot of connection. So connecting them with local experts, connecting them with one another. We also have convened a opioid settlement coordinator network. So we're building a workforce across our state of folks that are new to the settlement, but really building that expertise and helping them tell their stories, right? So I think Cecilia alluded to this too, is that we're really trying to empower our local governments to be able to represent the good work that they're doing and back that up with their data. And so that includes qualitative and quantitative data sources. But really we're about coaching, connecting, cheerleading sometimes, but not wanting to, lose this opportunity to do really good in our community. So our hope is that we'll get to that point. But, and we can get into this in more detail in the Q&A if that's helpful, but in North Carolina, in the MOA, it's somewhat of an alphabet soup, to be honest, but we have many exhibits. And so Exhibit A is a list of high impact abatement strategies that our local governments can choose from. There are fewer administrative requirements to access this list. It's basically a vetted list of evidence-based supported strategies that we have really good examples of all across our state of it working. But if anyone is into talking about root causes, risk and protective factors, and sort of this balance of crisis response as well as improving systems of care, I think this Exhibit A list is a really great summary of like things that we can do. And so I'm just going to dance through them really quickly if you're interested, but collaborative strategic planning is essentially this idea that, you know, the epidemic is dynamic. We really got to do our best to make sure that our response keeps up with the changing landscape of what the drug overdose crisis looks like. And it really just helps to sort of support the staffing, the infrastructure, the data management, the partnership nurturing that happens at each of the local government levels. The number 2A2 strategy is evidence-based addiction treatment. Evidence shows that people who have access to medications for opioid use disorder are 50 times more likely to survive. It's gold standard of care to have access to methadone, buprenorphine, naltrexone. And so our goal is to really increase access to evidence-based addiction treatment in any and all places in an affordable, accessible, acceptable way. So that includes through our local health departments, through our EMS bridge programs, through federally qualified healthcare centers, through emergency departments, and honestly anywhere that patients interact with the health system. We want to make sure that it's available and accessible for patients to get access to medications as they need them. Recovery support services, recovery housing support services, and employment-related services are really getting to those sort of root causes of drug use, and this idea that drug use is very much about like disconnection, and we're trying to connect people to care and services and people and community and those sort of basic needs in Maslow's hierarchy. And so these are both preventative services as well as sort of caring services, because we know that people who have access to housing are less likely to use drugs, and people who use drugs are less likely to have stable housing. And so how do we do our best to sort of break that cycle and dig in deep to what those really root causes are for drug use and try to support people in the long run so that they can have, you know, purpose-driven, meaningful, stable, healthy lives for the long term. Early intervention programs are really acknowledging the fact that trauma is the gateway to drug use. And so how do we do our best to break generational cycles of trauma and really support kids and adolescents that are already showing signs of struggle? Mental health conditions generally show up in young people before substance use does. And so how do we basically prepare the adults, the caring, loving adults that are with or around those children to recognize signs and symptoms of struggle, and then ask the question, where does it hurt and how can I help you? And really doing our best to like intervene and try to prevent more chaotic use for young people later. The strategies, naloxone distribution, if y'all are, I'm like sure you all are familiar, but naloxone is a first aid medication that saves lives. It does nothing else but restores breathing. And so we're trying to get it out into community as much as we possibly can. And so that's through all channels, all possible channels. But post-overdose response teams are called quick response teams in other places. They're called by many names, but really the idea is that people who have overdosed are more likely to overdose again. And so how do we do our best to connect folks to care and services in those sort of critical 24, 48 hours after an overdose to say, golly, that must have been a really scary experience. I'm so glad that you're still here with us. What kind of care and support do you need and how can I connect you? And so we work really closely with our EMS and sort of harm reduction peer navigators, sort of that magic combination to try to get folks connected to care. Certain service programs were legalized in North Carolina in 2016. I can't believe it's almost been 10 years now. And it's essentially connecting people sometimes in our most darkest corners of North Carolina to light and services and loving connections. So we are there's many decades of evidence that show that certain service programs reduce disease transmission, increase people's connections to treatment, recovery support services, and do a whole range of services, not just about handing out sterile supplies, but also helping them navigate job applications or housing applications, or get them signed up for health insurance or food or whatever it might be need that they that they're trying to navigate. Criminal justice diversion programs, addiction treatment for incarcerated persons, and reentry programs are based on the fact that in North Carolina, at least, people that are involved in the legal system are 50 times more likely to die in the first 2 weeks of being released, which is really not okay. And so we're trying to do our best to divert folks who are much better suited to be cared for in the healthcare system than in the justice system. And so criminal justice diversion being get them out of the system before they even get arrested or get charged. Addiction treatment, meaning let's increase access to medications for opioid disorder and healthcare services while we have them in our facilities. And then reentry is easing transition back to community and trying to reduce recidivism and sort of repeat engagement with the legal system. It's also an acknowledgement that certain populations, especially Black and brown folks, have been overly policed and overly harmed by this racist drug war. And so how do we do our best to sort of right the wrongs and focus in on populations that are hardest hit by sort of multiple levels of challenges? So not only justice involvement, but also decreased access to healthcare. We don't make it so easy for them to navigate life and community and other resources. And so wanting to really pull those strategies out because they need extra attention and extra care. So this is sort of our major list of strategies, very much sort of data driven, in that we've got good examples, we've got good evidence of programs that are working across North Carolina. We're really trying to share those lessons across our local governments. There's an additional Exhibit B, which is essentially the National Opioid Settlements Exhibit E. Again, totally, I warned you about the alphabet soup. But the difference between A and B in North Carolina for me is that Exhibit A is very much focused on trying to keep people safe and alive. These are strategies that are much closer to the people that are at highest risk for death. And then Exhibit B is much more sort of peripheral or ripple effects. There's sort of systems of care that are a bit of, a couple steps removed from the patient. So all like good strategies, but definitely at this point, losing 9 people every single day in North Carolina, we really are trying to keep people safe and alive. So, and prioritize populations that are hardest hit. So I can get into some of those more programmatic details at another point. But I want to reemphasize the partnerships are really key to success in North Carolina. We can't do this work without each other. People ask us like, what is the magic sauce or what is the sparkle? And I'm like, honestly, it's the relationships, it's the trust, it's the fact that like we've got each other, we all know what we do, what we all do well, and we give each other room to do that, and really defer to each other's expertise, but like celebrate the fact that like this couldn't happen without one another. So I also just want to acknowledge that like our collective history is one that started way back in the 90s, really. North Carolina was the first state to sound the alarm, and we called a CDC EpiAid to come when we realized that poisoning deaths were increasing, and it was no longer the Drano under the sink. It was actually prescription medications. And so we had a CDC Epi team come down, go through all of our death records, and identify that it was prescription drugs that were actually at the time poisoning more folks. And so over the sort of waves of the epidemic, prescription medications, and then heroin, and then fentanyl, and sort of now this polysubstance use epidemic, we've had quite a number of data-driven surveillance, policy, programmatic sort of milestones along the way that we think are at least helping collectively reduce the number of overdose deaths that we're all experiencing in every state. Or at least the trend's going down. Let's hope it stays that way. But I also wanted to just alert you all to the North Carolina Opioid and Substance Use Action Plan. So we're, I think, in our 3rd version of it now. But essentially, thanks, Amanda. Essentially, this is this acknowledgement that like we must center equity and lived experience in the epidemic, and that we have to, both like we have to prevent and we have to reduce harm and we have to connect people to care in this sort of like cyclical way. But it's also very much surrounded by data. So we're tracking our progress, we're measuring our impact, and we're monitoring emerging trends because we've got to keep up with how this is changing so quickly. The conversation I was having 20 years ago when I started this work is very different than it is now. And people who use drugs are more likely to tell us before our data ever will where our systems are failing us and where the opportunities are to improve. And so we really do want to make sure that we're listening. I also want to point out that our DHHS partners have put together an incredible dashboard called the North Carolina Overdose Epidemic Data Dashboard. This is where we keep up with state trends. I think it's a beautiful website. I'm also a data nerd, self-admitted. And I think they just do a really good job of featuring some of our more reliable data metrics and measures like overdose deaths, ED visits, our buprenorphine prescribing based on our PDMP data, foster care numbers based on DSS data, and a couple other sources. But it's a really great website, so check it out. This has been around a lot longer than our settlement work has been, but our ncopioidsettlement.org website that Cecilia was telling you about is a really good complement to this state dashboard. And then also Amanda will tell us a little bit more about this in detail, but a few years ago, we had put together a research agenda that included a set of key research priorities and questions that we identified through working with partners, and it was time to update it. So before the pandemic, we had one set of questions. Thankfully, our research community in North Carolina is really robust, and we were able to answer quite a number of them. But we also acknowledge that during the pandemic, things changed a lot. And so we needed to update our research agenda and make sure that the questions were relevant, were actionable, and informed state and local policy. And so I just wanted to sort of thank Amanda as I pass on in a few minutes the conversation to her, to just say, like, we really do appreciate the Institute's very meticulous, careful, conscientious way that we engage with partners to try to come up with new questions. I think we're all the type of researchers who want the work to matter and not just be sort of for funsies, but really be what is the need that our communities are asking us for? What's the big question that our communities are asking us for? And then how can we as researchers answer those questions, build the evidence, help build momentum behind things that are working, and inform really smart policy. And so another thanks to our key collaborators, the North Carolina Department of Justice, NCACC, UNC's Injury Prevention Research Center, and our partners over at NCDHHS. It is such a pleasure to work with all these people. They're so smart, they're so bright, so passionate, so committed. And I love what I get to do every day with these folks. And so just another thank you. And then also our supporting partners. We couldn't do it without the North Carolina League of Municipalities that covers all of our cities, because in North Carolina, all 100 counties and our 17 of our largest cities get funding through the settlement, as well as our partners at the UNC School of Public Health, where I graduated. Thank you so much. And the North Carolina Collaboratory. So if you want to be in touch, would love to continue this conversation at any point. I think we did a really smart thing, and our email address is really easy. They're basically just opioidsettlement @ and then all of our core partners. So at ncdoj.gov, at ncc.org, at unc.edu, or at DHHS. So please be in touch for continued conversations, partnerships, curiosities, whatever you got. But I'm going to now pass it along to my dear friend and colleague, Amanda.
Let me unmute myself and I'll do the annoying, can everyone see my screen? Yay, thank you. So good afternoon, everyone. Thank you so much for choosing to spend your Friday latter part of the day here in this discussion today. My name is Amanda Dale. I'm a research specialist with the North Carolina Institute of Medicine. I've been working with the Institute since I was a graduate research assistant back in 2021, and I've been on the team full-time for a little more than a year since then. So today I'm going to be talking about our organization's support for state and local planning for overdose prevention, with a specific focus on our partnership with the Association of County Commissioners to develop an updated state opioid research agenda. So a little bit about, let me move this thing, a little bit about the NCIOM. We were chartered by the North Carolina General Assembly in 1983 to be concerned. We have a very broad charter, and it is to be concerned with the health of the people of North Carolina and to respond authoritatively to requests for health policy analysis from state agencies and other concerned parties. One common misconception about our organization is that we do primary peer-reviewed academic research. In reality, we use primary research and we leverage it as a tool along with our relationships and partnerships with cross-sector organizations and with content experts to drive consensus-based solutions to our state's most pressing health issues. We're committed to better health for all North Carolinians, and especially those who face challenges because of what they look like, where they live, or what's in their wallets. We are an anchor organization that convenes diverse perspectives for a common goal, and we're forward-looking and solution-focused. We receive a pretty even mix of public and private dollars. Sorry, these things are, let me hide that. So we receive a pretty even mix of public and private dollars, and we're administratively housed at the Shep Center for Health Services Research at the University of North Carolina. And so generally, just in the past few years, we've completed task forces on a wide breadth of health issues, including healthy aging, bolstering our local public health infrastructure, supporting the nursing workforce, oral health. And so people often ask how we decide what projects and what initiatives we take on. So generally what happens is that entities like the General Assembly, our Department of Health and Human Services, or philanthropies will approach us to study a specific health issue and subsequently provide the funding and support to pursue those efforts in responding to the health issue. Some of our ongoing funding partnerships include those with the Kate B. Reynolds Charitable Trust, the Duke Endowment, the Blue Cross Blue Shield of North Carolina and North Carolina AHEC, and or our Area Health Education Center, and I've specifically bolded the Duke Endowment and the Blue Cross Blue Shield of North Carolina because those are the funders who've supported our partnership with the the North Carolina Association of County Commissioners. We do our work by bringing together subject matter experts and the people who are closest to a health issue to critically examine the health issue, to appraise potential solutions and insights, to identify levers of influence that can really make a difference in these issues. These collaborative and iterative discussions often result in actionable recommendations that the North Carolina Institute of Medicine then publishes and disseminates to those influencers in our networks. And we aim to impact what we call both big P and little p policy. So we are not an advocacy organization, but our analysis is often used by advocacy organizations or legislators for developing their own policy agendas. Or on the little p side, professional organizations or healthcare providers have often used our findings and our recommendations for their own strategic planning within their health systems or health facilities. I want to start by saying that at the Institute of Medicine, we really like to call ourselves health policy generalists. And what we mean by that is that we all individually might have our own expertise in specific health topics because of our education or professional experience, but it's really often that we're presented with projects that we didn't have a lot of familiarity with prior to our exposure to that said project. And with a lot of vulnerability and humility, I will say that was the case for me when I was assigned to this work when I was a graduate research assistant with the Institute of Medicine back in 2021. And I really can't thank our panelists enough, along with other subject matter experts in the state who were so patient with me, especially earlier in this work as I stumbled my way through all of the different efforts we'll talk about here today. And for, as an example, in this report that I'm about to showcase right now, I write a lot about substance use disorder. And actually, if you looked at my title slide, a lot of my organization's framing of this work is around this term, substance use disorder. And I just want to acknowledge that in actuality, a lot of overdose prevention and those high opioid abatement strategies in the MOA are not just for people who meet the diagnostic criteria of having a substance use disorder. It's, anyone who uses drugs can benefit. And, these strategies are applicable to them as well. So I want to say that the words that we use when we do this work really do matter, and I wanted to acknowledge that as I continue this presentation. So a large portion of the funding for our partnership with the Association of County Commissioners was supporting their ongoing technical assistance efforts across the state. So at the NCIOM, we had far fewer externally imposed deliverables and deadlines, which gave us a lot of flexibility on our end to sort of create products that would be supportive in the endeavors of our partners. And so our first activity with this grant was a landscape analysis of organizations providing substance use education, prevention, and services across the state. This was in late 2021 into 2022. I conducted interviews with 62 folks working in substance use services across the state about the challenges and opportunities of the current resources that they had available to them, but also the forthcoming opioid settlement funds that were just at the very beginning stages of that 18-year disbursement period. And our goal was to understand their current challenges faced by people who use drugs and the people that serve them, and to represent this really important snapshot in time. What we found through this report was that, it is necessary for there to be transparency and accountability with opioid settlement decision-making, which is what makes CORE&C and the association's work so important, and being transparent with how counties and municipalities are making funding decisions. We also saw a desire for capacity building related to equity, and we also saw the critical need for housing, transportation, and employment supports. After the publication of this report, we continued our conversations with the association and partners at the Department of Health and Human Services and the Injury Prevention Research Center to identify another opportunity, as Nidhi said earlier, to support the work of our partners, and that was to update our state's opioid research agenda. Back in 2018, our state Department of Health and Human Services convened a group of researchers, practitioners, and DHHS representatives to identify a list of questions that that were meant to be answered in the short term and that would generate the state with information to strengthen our strategies to prevent overdose at that period of time. And I feel like 2018 does not feel like it was a long time ago, but really so much has changed. Since then, we saw both the devastating impacts of the COVID-19 pandemic, but also the opportunities that were provided to us through the bolstering of telehealth infrastructure during that time. We saw an increase in fentanyl positive deaths and polysubstance use, and even more recently, specifically co-use of opioids and stimulants. We saw an increase in North Carolina in overdose death among Black and Native people. We saw the buprenorphine X waiver elimination. We are now on our third iteration of our DHHS state opioid and substance use action plan. And of course, most relevantly to our talk today, we saw the availability of opioid settlement funds and related technical assistance. So this was approximately about a year-long process where we started in March with convening a group of approximately 30 thought partners. This included folks from the Institute of Medicine, from DHHS, from the association, from local health departments and harm reduction organizations, prevention experts. And we had 3 meetings between January and March, and these meetings shaped the goals of our convening. They informed the timing and length of the convening. And they also, during these conversations, we had the suggestion of the creation of a people with lived experience advisory group to ensure that if we were trying to center the experiences of drug users and people who have experience using drugs, if we're going to do this in a shared space, we wanted to be sure that space was accommodating and safe for those people with lived experience. And an important part of this thought partner process was actually the development of what we called our research domains going into the meeting. So these specific discussion groups at the convening were folks were developing research questions, and those research domains included destigmatization and culture change, evidence-based treatment, harm reduction and overdose prevention, policy impacts, and social determinants of health and recovery supports. Between March and May, I convened focus groups and interviews with people with lived and living experience. And through these meetings, they helped shape our discussion principles that informed ensuring that space at our convening was safe emotionally and also, physically for people. And also contributed to our facilitation guide. They identified potential barriers to engagement for people with lived experience and for harm reduction workers. So for example, a lot of harm reduction organizations their funding is only to provide direct service provision. And so many people who work in harm reduction organizations were not able to take a full half day or maybe even longer to drive and participate in a long convening because that was not under the purview of direct service provision. And so we were able to work with our funding to be able to provide stipends to people who are not otherwise paid to be there as part of their everyday work. And of course, also identify the need for mileage reimbursement. All of us, I think Nidhi, Cecilia, and I were all based in the Triangle. And we know that, the needs of our state are so diverse when you're going from east to west. And we wanted to ensure that mileage was not a barrier for people who really wanted to be there. And finally, in July, we hosted our convening. The goal of the convening was to facilitate a collaborative process centering people with lived and living experience, but also including researchers, practitioners, public health and policy professionals to identify a list of questions that was meant to guide research and evaluation efforts, to inform best practices and the effective use of resources, and namely opioid settlement funds, to bolster our ongoing response to our dynamic overdose epidemic, and to promote the health and dignity of people who use substances in their communities. Something that was really illuminating to me when engaging with our advisory group was just how much, and understandably, how much of the research was focusing on overdose, which is really important, of course. We want to save lives, but at the same time, they felt that there was this restrictive research focus on overdose and on connecting to treatment or of recovery or sobriety. And so they really wanted to sort of promote a research environment that was thinking about health in a more holistic way. So, people's connection to community, people's ability to secure housing, to maintain their relationships, maintain, earn and maintain employment. And so we wanted to, broaden our outcomes that we were looking at going into this convening. At the convening, I'll say the convening generated 84 unique research questions that are on some of those, if you see in the picture, on some of those sticky pads to the walls. At the end of the day, we had a gallery walk, and I think everyone had like 5-star stickers, and we went around and we asked people at each research domain station to vote on a question that they thought was the most critical to include in our research agenda. So after that, I took all of those questions home. Questions that had a certain number of votes on it were included in a post-convening survey. So that ended up being like 40 questions that people were then asked to rank and vote based on how critical they thought those questions were. And we ended up with 13, well, I'll say 11 research questions and 2 what we call research priorities. And so I didn't list them all here today. My last slide has my email. And so if anyone wants our executive summary of this research agenda, I'm happy to send it. But our research priorities were themes that reflected cross-cutting priorities that were essential to meaningful and respectful scientific inquiry. So not something that would be good for one specific research question, but sort of values and priorities that we need to do any research in this space. The first being balancing prevention, treatment, and harm reduction efforts to save lives. As Nidhi showed us, the MOA, we have a wide spread of strategies. And I think if counties could, they would want to put forth investment into everything. But unfortunately, different communities have varying needs. And so being able to balance sort of the returns that communities are able to see investing in prevention, treatment, and harm reduction, and trying to see, what is that right balance? And also recognizing and addressing stigma across sectors, because in respectful scientific inquiry, and also to ensure that research is meaningful for the people that it is meant to impact, namely people who use drugs and people at risk for overdose, it's important that we address the stigma within research institutions, within community organizations, public health, to be able to continue fostering those meaningful partnerships. And as for research questions, we have some illustrative examples. We wanted to ensure that the majority of our research questions would build evidence around specifically our Exhibit A, MOA strategies. So those high impact opioid abatement strategies Nidhi shared with us earlier. So for example, we had a question about ready access treatment strategies. So that includes, take-home doses, telehealth, EMS bridge programs. What impact do those have on treatment initiation, retention, and recovery? Do these outcomes vary by community? What are the facilitators and barriers to communities in providing various ready access treatment strategies? And we see that those are supporting evidence-based treatment and also post-overdose response. Some of our questions were really cross-cutting, so it was difficult for us to map them directly on an MOA, a specific MOA strategy. So given the current challenges of the overdose crisis, for example, the co-use of opioids and stimulants, what policy and practice changes are needed to provide effective care? And some there was like this research question, I think, was the only one that did not cleanly map onto any of the high impact Exhibit A strategies, but was far and beyond identified as being very critical to impacting the lives of people who use drugs in our state, which is what impact, if any, does the North Carolina death by distribution law have on overdose deaths, and 911 calls after an overdose? And has this effect varied by race, ethnicity, or county/geography? So looking at rural versus urban spaces in our state. Our next steps are to complete and disseminate the agenda report. I've already, IOM, we've already met with the association, but pretty soon we're also going to be meeting with our Injury Prevention Research Center folks and our folks at DHHS to discuss this dissemination. Because a little bit of what's happened between the culmination of that convening process and now is we've had Hurricane Helene, and so those are potentially additional considerations that we need to include in the broader report. And also we did have a federal and also state administration changes between then and now. And so we understand that there's a changing research landscape, and we just want to be sure that we do our due diligence to faithfully convey what was identified as priority through our collaborative process, while also ensuring that researchers are equipped with what they need to pursue these questions. And those are my references. And if anyone in the audience wants a digital copy of our executive summary of the updated research agenda, you could please take a picture of my email. I'm happy to email it to you if you just send over a request. But thank you. And with that, I'll turn it over to Donna.
Sorry about that. Thank you so much. It was a really interesting set of integrated presentations, and I have a lot of different questions for you, from high level to in the weeds. But I just want to ask two in the weeds questions, and then we'll open it up to others. The research that you just described, the research agenda that you just described, Amanda, will that be funded with the opioid settlement funds, or would you go out to federal levels or other sources to fund that work?
So I will let Nidhi speak a little bit. There is one option B strategy, which is the broader, or they are the broader spectrum of strategies that can be funded should a county pursue complete strategic planning. And one of those option B strategies is research, and they actually have some specific topics that opioid settlement funds are allowed or able to fund. And so this is meant to build evidence around the MOA, but this research is not necessarily meant to be supported with the funds themselves. And I'll pass it to Nidhi to speak more.
Yeah, so everything that Amanda said, and then also, if you remember that in North Carolina, 15% of our funds go to the North Carolina state. And so they are able to allocate to like the North Carolina Collaboratory, which then has built a research portfolio, like Cecilia was talking about, with like a really intentional directive to partner researchers with community-based or local government representatives. And so that's one way that they have funded research in North Carolina, is through that 15% that goes to the state. But no, I think this research agenda is really meant to just collect a list of questions that are most relevant, impactful, potentially informative to policy, regardless of what the funding source is. And so the idea is our research community, we would want to activate them to say, this is what our practitioners are asking for. If there's anything that feels sparkly or interesting or exciting to you, that fits within your expertise, like, please, go for it. And look for whatever funding might make the most sense. So whether it's private dollars, foundation money, or state or federal research monies.
It helps build the rationale for the research with other funders, given that this process was so
yeah, that's very true too. Yeah.
Okay.
This is what communities are asking us to answer.
Great. I noticed that the first presentation, Cecilia, when you showed the map of North Carolina and the counties and localities that were participating, there were several that weren't lit up yet. They were still gray. I'm just wondering what the significance of them is. Is that is participation required in the MOA?
Yes, so I think you were referring to the local spending plans, the state view dashboard that shows our current track of which local governments have approved and shared opioid settlement spending plans. So we are reaching 100%, but we're still not quite there yet. And generally speaking, the local governments who have not yet allocated funds towards opioid strategies, there's a few reasons. It's either that they already have another source of funding that they are choosing to spend down first before they start utilizing their opioid settlement funds. So they're kind of letting the opioid settlement funds sit and maybe gain interest and use those once other existing funds are run through. The other is that there are some local governments who are going through a pretty comprehensive planning process. They're doing needs assessments. They're working with either foundation grants or other outside consultation groups to help them determine what is best for their communities. So we don't necessarily see it as a bad thing when we don't see 100% lit up on that map yet, because we do want to believe and support that our local governments, in having full autonomy in deciding what is best for their communities, that they are taking that seriously. And they are having these required annual meetings that include folks with lived experiences. They're gaining information and knowledge, and it is what is best to, what strategies are best to fund in their communities. And I'm not sure if Nidhi, if you wanted to add more there.
Yeah, so everything that Cecilia said, and then also in North Carolina, local governments are not required to spend the money in the year that they receive it. There's no expiration date like grants that we're used to, where we're like, oh, you have 1, 3, 5 years to spend the money. In this case, it doesn't expire. And so they could potentially even have funds to spend after the 18 years are done. And so, like Cecilia said, a lot of them are choosing to spend other funds that do have expiration dates first. And also just for scale, like some local governments are not actually getting that much money. Like they might be getting only tens of thousands of dollars a year, and they might be saving up for a larger project or a capital investment or something that needs a little bit more time, or they're trying to pool funds regionally if they're smaller counties or especially rural, and they just don't have the market to necessarily entice a particular kind of service to come to their area. And so they're trying to navigate some of those challenges. And to the question that's in the chat, which I think also speaks to this point. So the way that North Carolina, and I think most state governments in the country figured out their formula is it was based on 3 different things. It was based on population, the number of pills dispensed within that community at that time when they were going through the settlements, and the number of overdose deaths. And so the Mecklenburg counties in North Carolina are getting, millions and millions and millions of dollars. And some of our more rural counties like Hyde County are getting tens of thousands of dollars. And so like just the scale and the scope is something to sort of keep in mind. And so I would imagine in the next year, all of those counties that don't necessarily have local spending plans just yet will probably come online. And also, honestly, I would much rather them take their time, as Cecilia was saying, that they're going through their collaborative strategic planning process to like make a good decision than to rush to a bad one. So
Thank you. I mean, Amanda, I think Amanda Fuller, I think your question is kind of related to that.
Yeah, my question about how the money is distributed among the counties.
yeah, so it's that 3-pronged formula: population, number of pills dispensed, and the number of overdose deaths. And then the payments over 18 years really depends on the defendant or the company that has gone through the litigation and lawsuits. So like if you'll notice the payment schedule that Cecilia and Catherine showed, we are actually front loaded. So more money is coming to local governments in the beginning, in the first few years, and then it sort of peters out. And this essentially means that like the Walmarts of the world, for example, can afford to pay out their settlements in a year, but some of these smaller companies need to spread it out over 3, 5, 10, 11, 18 years. And so that's essentially what happens, is that different defendants are kind of coming up and online over time.
It reminds me a little bit of the tobacco settlement money when that was distributed. And I haven't been in Kentucky the whole time, since that was started, but it tapered off in a similar way, and we're getting toward the end of it now. But that was sort of the point of reference that I had when I heard about this. So thank you for sharing that.
Yeah, for sure. Thanks for the question.
Okay. Does anyone in the Bridget, you had a question in the chat?
Yeah, it was more of an observation, given how much interest people express in having grant funds that are not so tied to specific year cycles and expirations and this kind of flexibility in planning. It's actually a really great, just natural experiment in whether or not the outcomes of changing how grant money works would be what we predict. So I hope that I know you have a lot of other things, a lot of other stories you need to tell in terms of what you're learning, but I hope that you get a chance to tell that one as well.
Yeah, I think we could all. And we'd all be curious to see how different grant structures would work. Yes.
We provide, within our impact report, we do provide a really great opportunity for all of our local governments, in their own words, to provide not only an overall summary of what they've accomplished in any given fiscal year, but then for those who did disperse funds, they provide us with a progress report on what they accomplished in that fiscal year towards funding that particular strategy. And then a lot of our local governments are also, as part of their impact reporting, providing us with success stories. So they actually, again, in their own words, from either a provider of their services or someone even internal in their own staff, they're able to provide us with a success story that, again, what we hope to do across this funding period is to teach our local governments who have the best of intentions, who do such great work, but who might not be well versed in public health research and telling that story. We're trying to help them along the way to learn from each other, but also learn from examples of what we hope to see in terms of an overall summary statement of what they've accomplished in a given year, or what we're looking for when we ask for a progress report or a success story, so that we understand as researchers that we're only as good as the data that we receive. And so it's incumbent upon us to kind of hold our local health, local government staff, just kind of hold their hand a little bit, help them understand what we're looking for and why it's so important, so that they can tell their story of success and they can have a better chance in getting prolonged funding even once this 18-year settlement period is over.
Yeah, and I think there was a very noticeable difference between year 1 and year 2 for us in the quality of data that came through. And that was a lot to do with the very specific guidance that we gave, coaching, training, at our network meetings. We provided tons of one-on-one technical assistance around reporting with special office hours just for evaluation and reporting. And we really try to make ourselves accessible just to hold their hands and also just coach them up, because they are so humble and often very shy about sharing their successes. And we're like, no, this is very unique and unusual and should be celebrated. And the public wants to hear it, and tell your story. And these unsung government bureaucrats that are throwing their hearts into their communities and trying to do such good work, but just are too, hesitant to share it loudly. So it's a lot of encouraging them to do that. So we've been really proud. I think we just had a big milestone today, actually. The technical assistance that OSTAT, or the Opioid Settlement Technical Assistance Team, has offered is we reached over 1,900 instances of technical assistance since we started our program, which is huge. I mean, that's when local governments are wanting to do the right thing, like Cecilia said, they just don't necessarily always know what that looks like or how to do it. And so it's been really, really encouraging to work alongside them to help figure out what to do, how to do it, and how best to talk about it.
So following up on that, I mean, it sounds as though you're developing an incredible esprit de corps within the state around this topic, which is really, really difficult in the first place, and trusting environment. And you may have said this in one of your presentations, but do you have regular convenings of these individuals who are working on this so that they can share with each other and get ongoing support?
Yeah, we have monthly office hours virtual for all local government settlement coordinators and elected officials or just government staff that want to come together and talk. It was, at first it was a lot of us sharing information out, and then you can start to see them building their confidence, and they start to like give each other coaching and advice and like, this is what I've learned, this is what works for me, which has been really, really fun to see. So we encourage peer learning at these virtual monthly office hours, and then we also bring them together in person 3 times a year and do like training, sort of like longer in more in-depth conversations about a particular topic. We at least have one of those 3 trainings are sort of focused on reporting before we launch the portal and sort of open the reporting season. And then we also have the summit, the North Carolina Summit on Reducing Overdose that is convened every other year. And so that is a statewide conference that just kind of dances through the different strategies, really celebrates the recent successes, and offers more timely training depending on kind of what's going on. But we just held one in March of this year that was a real big success.
Thank you. Thank you.
Mhm.
Amanda?
Well, and similarly, like as you all are describing, the counties learning from each other and supporting each other as they go through this process. Of course, my next question is, how do the states learn from each other? Like the whole reason that we're here today is because we are interested in, I'm so curious about this. It like raises so many interesting questions for me now about like, what is my state doing? It's not something that I've really followed so far, but how can we learn from this? And is anybody tracking nationally, like how different states are handling the money? And yeah, how do we find out about that?
Yeah, I think Catherine's probably getting the National Opioid Settlement Tracker link to put in the chat, but there is a website that includes all the different state allocation models, links to different guiding documents or whatever it might be for that particular state. So you can take a look at that resource.
Excellent.
And yeah, we as a precursor or a pre-conference to our summit, we actually held and hosted the first national convening of opioid settlement coordinators. And so we had 25 states represented that came to North Carolina for us to get together and talk about just what we have in common, what we can learn. And honestly, like part of it was also just peer support amongst ourselves because this is such a complicated landscape and it is just so nuanced depending on where you are. And so one recommendation that I would have is to take a look at that nationalopioidsettlement.com website that Catherine put in the chat, but then also reach out to your own state county associations. I know that in Kentucky, for example, they're building up a technical assistance team or technical assistance effort similar to NCACC. Probably not as big because they're a bit of a smaller organization, but they're working to sort of build up that infrastructure. And then also Kentucky has a sort of counterpart to IPRIC. So KIPRIC, the Kentucky Injury Prevention Research Center, I think has also been really involved in this space for a long time. So just for an example, take a look in Kentucky to these couple places. And then your state attorney general will probably be a really good resource. They're oftentimes the sort of convener since they're the ones that are at the center of the litigation and are in charge of sort of defending your state agreements. And so they'll have some pretty good ideas probably about who you might be able to connect with in your own states.
And
Yeah,
just to
that's great.
add on to that, Catherine and I have actually met with Kentucky representatives multiple times as well. They've posed lots of questions to us in terms of our dashboards, how we went about everything. We've also consulted kind of informally with multiple other states, Maryland, Florida,
Carolina,
West Virginia. Yeah, so we've definitely made ourselves available to any state who wants to learn. And again, one of the running themes of that state convening that Nidhi referred to at the North Carolina Summit is that we understand that, again, North Carolina is very unique in its approach, and it's also very unique in that it does have a legal binding document that requires all of this reporting mechanisms, whereas a lot of other states didn't build that into their opioid settlement structure. And I think, the general consensus is from other states is how to get this data that they really, really want when it's not necessarily required of the recipients of the funds. So, but we've worked with other states to just help them understand what they could do or what they could encourage in terms of getting some of that rich data, and how we built some of our dashboards that might be useful for them.
Great, thank you. We have one more question and then we'll have some closing remarks. So Vinay, Raj?
Yeah. I was curious about how in your research you factored in hospital costs and especially the healthcare costs related to this issue. And the last one was like, I know you have your dashboards and all that, but is the data publicly available, or could we sign up like for research purposes to understand the data better? Is there some kind of an agreement we can get into to get the raw data? I mean.
Yeah, so I'll answer that second question. So yes, all of our data is publicly available. It's all based under Tableau. So you can, I think Catherine just put in the link in the chat where you can download all of the raw data. That's on our website. And then we have also on our website, you'll see a lot of technical notes that will link out to explain some of the nature of the data. But then yes, everything that we have on our website is publicly downloadable for anybody to really get their claws in there.
Great, we
Thank you.
love data. Thank you so much. Well, we only have a couple of minutes left. I'd like to just, first of all, thank everyone for coming. Thank you for your great presentations. It's just really exciting to see, my takeaways were that it's possible to tackle something this big by collaborating across adjacent organizations who share a vision at the state level. And I just think it was really great to hear about that, and gives us hope. I'm going to take a closer look at what's going on in my home state here of Washington to see if there's anything even similar to this. So really appreciate that. The other thing is, this really is a long game. It's nice to hear that this is an 18-year commitment that you're making, which is really professionally quite a commitment. Not suggesting that you are going to all stay in this for 18 years, but if you do, wow, that is going to be such a contribution to public health. So I think we'll learn a lot from you. Thank you again. We are going to send out a survey after this, and we please ask you to fill it out, because we would love to do more events like this that could be of use to everyone. And I really, it's given me a lot to think about. I live in Seattle. We see the traces of the opioid epidemic, and then heroin, fentanyl as well, all around us, and we're struggling with ways to deal with it. And so I hope that we here in Washington State can learn from you. Thank you. So thanks, everyone. And thank you to the audience, and we hope to see you all soon. Malvern, any final words?
No, yeah, just to say thank you, everyone. And I think we hope this is a good start to a long relationship.
Yes. Amanda?
And I just wanted to plug for my Academy colleagues who are here today. We have these programs every month. In May, our next program is going to be with the Council on Undergraduate Research about supporting undergraduates on their research journey. And the rest of those programs every month are on our website, scheduled up, as we get them through the year. So hope you'll join us for future programs.
Yes. Okay. Thank you, everyone, and have a great weekend.
Thank you.